Now, we are in front of the patient. We have to decide what to do. It means that we have to do a new case in this particular situation, and so we push the red button over here, new case. Of course, together we have the library and in progress cases, so case that were already examined but not finalized yet. So now we are approaching new case and we push new. And of course, before starting, we have an alert that is explaining us that we will talk not about the fact to maintain, to keep or to remove a tooth or position implant, but just about the position of the teeth, orientation of the occlusal plane, and the position of the teeth in terms of length, to be more apical, more incisal positioned, or to be more buccal or more lingual positioned. Once we understand that, we start to collect the data about the patient information. Of course, we can write here my name and my surname. Then we go to the patient, and of course, we have to write down also the name of the patient, surname, and date of birth is important because we will interact with the GETApp, with the application, knowing the age and the sex of the patient will be absolutely important, and we will memorize all the data inside GETApp. It will be very important later. So this guy is March some years ago, not so much, it's 52, okay, and this male. Done. So next step, we go ahead with the red arrows on the bottom. So now we have another alert over here, and the question is, do you wish to proceed with an anamnestic evaluation? Normally I say not, because I have already all the data in the chart of this patient, so I don't need to say yes. Normally it's not, but if you want, of course, you can have the complete one or the simplified one. Now we ask the patient, what about the perception he or she has about his or her mouth? What is the problem that he can really see in his mouth or in her mouth? In this particular case, the patient was aware that the teeth are really worn out dentition in this situation. We have a short teeth present there, so we want to restore his teeth in this case. So, what about the functionality? What is complaining is about the masticatory dysfunction. So we push the red button on masticatory dysfunction. Go ahead. And now the next question is, what you believe should be the treatment? What kind of necessity you have in your mouth? And the patient realized that he needs to have a full and lower upper and lower arch to be treated completely, so the full mouth rehabilitation. So that is a point, important one. Now, after having checked all the data, we start to say, what about the alignment? So again, the patient can in some way discuss with you, what about some appearance that can be young, as an adult, mature. In this case, you want to have aligned teeth. The appearance should be not young, not mature, but maybe adult. About tooth type, you want to become less square than now, so more ovoid. Some light micro texture, a slightly characterized teeth. Of course, when there is a question, highly demanding patient, of course we put yes all the time because we want to push as much as we could our technician to do the best work as possible. Next, look in the upper arch. We have to check about the objective examination. What about the problem here? You have no gingival recession, not a particular one. What we need to understand, again, is the generalized wear, and anterior wear specifically. And of course, that is done caused by the parafunctional activity of this patient. Now we check the skeletal class of this patient, is more or less class 1. And now we start to do a picture of this patient. After having finalized the pictures with the mask and with the level that we have seen already, we go ahead. Now we have some additional optional photos, pictures. We can avoid it, we can go with the red arrow down here. And now we go to the videos of the patient. And we ask the patient to do some letters like F sound, S sound, and also natural rest position. So quickly, we have already recorded the F sound. That will be very important for the incised position from the lateral view, the natural smile of the patient, the natural rest position, and the S sound. All these phonetic sounds like F and S will be very important in our final decision how the position of the teeth has to be really finalized in the proper way. Now, going ahead, we start to collect other data. Starting from smile line of the patient, we can have to select which kind of smile line the patient has. We have already checked. We are between low and average smile line. It's more low smile line than average. That is the point. And now we collect this data. And then we go ahead. Now we can take a look about labial corridor and smile width. We can see in this particular case is quite wide labial corridor. It means that we can enlarge our arch just in case it will be needed. And the smile width, it means not the smile line of the patient, but how many teeth are visible on the posterior area. How large is the smile? In this particular case, we see that we can see up to the second molar. So 12 to 14 teeth. I go ahead with the red button here. And we check about the inclination. In this case, we have a not inclination, not right, not left, just vertical. So it's a perfect incline. Then, looking about the deviation, just in case we have an interincisal line that is not really in harmony with the upper lip filtrum. In this case, it's centered, so we push centered. Again, we go ahead with the red arrows. And now, we have to start to select one of the two central incisors. Of course, we are not looking for the perfect central incisor. We are looking for the central incisor that is more or less the closest one of the two, the closer to the ideal one. So we believe that in this case, the central incisor, the right side, will be the right one to be not copied, but to be optimized 100%. So automatically, the app will select also the opposite dentition, and it will be the central incisor of the right central incisor of the lower arch. Now the app is asking us, what about the length and the width of the central incisor that you have selected, the right one. And what about the exposure at rest? So let me show now. We will write the number. It precisely is 8.72, and then the width, and the width is about even bigger than the length, is 8.99. What about the exposure at rest? Exposure at rest is actually minus, and we can write exactly the number at this point is minus 3.5. We can also write down, sorry, that's it, on the opposite side. I can even write down on the, it's about 3.5 millimeter. Now, it's also important to notice that this value, minus 3.5, is really not a good number for us, because if you don't see the teeth, you don't have to put 0, but you have to put exactly the entity of the incisor third that is not visible. In this way, I want to give you an example. Just pushing the red button over here, you can have some explanation about what we intend for tooth exposure at rest, but I'm sure that everybody knows about that. But more than that, it's also important to notice, like this example, you have a negative value. In this case, on your left, you see that you don't see. I mean, you can understand that you cannot see the incisal edge, but the incisal edge, looking also the red picture, is shown that is 5 millimeter underneath the lip. It means that you have to sign minus 5. So going back to our value, we sign minus 3.5. So theoretically, the tooth length should be increased of about 4 millimeter to start to be visible. So that's an important step, because if you sign 0 and then you have to add 3.5, it will be completely different numbers. So you have to sign exactly how much is underneath the lip. So how short is the tooth exactly underneath the lip. Now we can go ahead, and at this point we check also the lower arch, and you see that you write the same number also for the lower arch. First of all, length, and the length is exactly at this point 8.73. That's the length. 78, sorry, 78. Then 8.78. The width will be 5.64, and the tooth exposure at rest is 3 millimeters. It means that is visible of 3 millimeters. Okay, now at this point we go ahead again and we check finally also the relationship between the upper and the lower arch. That's important. We cannot just talk about the statics but also about the function. At this point we need to know about overbite and overjet values. That's very important. The original overbite value is 3.5 millimeters. About overjet, we have an overjet, minimal overjet of 1 millimeter only. The next question is, what about your dental contact? And the answer is yes, they are in contact. And what about incisal wear? And about the palatal wear. Incisal wear, I want to explain better to you this topic. Yes, we have the incisal wear. And as soon as you sign yes, at this point, the upper will ask you how much. In this particular case, we have 2 millimeters of the incisal wear. So let me better explain about this concept of the incisal wear. It's very important because normally many dentists take the measurement from the external part of the upper teeth to the external part of the lower teeth, anterior teeth meaning, of course. So, but once you have some incisal wear, at this point you have a shortened tooth. So we still have the same kind of overjet counting from this area to this area. But at the same time, having this kind of incisal wear, maybe 2 millimeters like in this case, written here, you will have less functional overjet. The functional overjet here will be maybe 3 millimeters, and this area here, when you shorten the tooth, will be less than 3, will be maybe 1.5, just because a couple of millimeters are already the thickness of the incisal edge of this worn dentition. So, at this point, you have written this, and we know the overjet is minimum, it's just 1 millimeter. And then we also need to know about the palatal wear. Yes or no? In this case, we have no palatal wear, so we can go ahead and we can check it now from this kind of drawing here, that we can have the chance to move these teeth. In this particular case, we have this cuspid that is more out, and we can move it. You see that it's very easy done. You can use this in the proper way. For example, you can rotate this in one side, the other side. We can move and rotate. So it's possible to do what you want. Of course, this is very important also to communicate with the patient what will be your final outcome. Sometimes you ask the patient, in the meantime we delayed, we ask the patient, do you accept any kind of little rotation, for example, the lateral incisor? And maybe they said yes. But, for example, you do it this way. You try to move this more out. No, I don't like it. More in? I don't like either. What you would like to accept? Let me check. Now I can rotate this. I accept some rotation. Do you like this like that, like that? Or, on the contrary, do you like to be the other side, to be more internal, like this one, this moment here? So this way you can better explain what is your intention and what they prefer in terms of moving the teeth, if is needed. So in this case, we come back to the original, and we go ahead. In this case, we have the chance to see that one cuspid is more out, just going back one. In this case, we have the chance to see that this cuspid is not in the right position, is more the buccal position. So you have to take into account this situation here, and we select this cuspid more out. Now we go to the lower. Lower are more or less perfectly aligned, so I don't need to do anything else. So I can go ahead now, and at this point we have to take a look about the over or under eruption, if does exist. In this particular case, we have no problem. Is a normal situation here, so the level of the occlusal plane is ideal. But if you maybe over-erupted like this case, you can also sign how much between the anterior and the posterior. That will be very important for orthodontic reason, but also for the need maybe to increase the vertical dimension in Furumawa's rehabilitation. In this case, we can add some height on the posterior area of the lower arch to compensate the over-eruption. So in this case, again, we are in the perfect situation. We are normally erupted, not over-erupted or under-erupted. So we go ahead and now we look for the inclination of the lowers. In this particular case, we could see that is a normal inclination, so we can put like that. But of course, is a way how to really idealize the case and to see if they are more out, more in on the normal position. What we have done until now is that we have collected data. So it's data collection, and we have followed all this red circle right now. This part, especially the first part of this area, can be covered by dental assistant, by another colleague, not a problem. At this point, we have finalized all these steps. So all the data collection are in. If I go ahead with the red button on the lower, on the bottom, you will see that we have some questions. This alert asks you, do you need more detailed data collection? For example, on color, on endodontically treated teeth, on the remaining dental structure, and also if you want to evaluate the periodontal health. All this information theoretically can be done already by this dentist, by the patient. But just in case you have not information, you can sign all this. I can show you what the app will give to you. It's not something that you have to do it, but it's some option. So you can do it or not, depending on you. If you have already this data, you don't need to do again, but if you don't have it, please do it. So we continue, and for example, we can sign the initial tooth color. In this case, we have been used the GETApp shade, and the original shade was A3, and the value was quite low. So normally, in this case, we need to increase the brightness of the teeth when you do restorative dentistry today. Many people want to become wider and brighter. So that's the reason why our goal will be to maybe lighten this smile to a 1, for example, with a higher value. So we have written here the original color. Then we will compare with the final one. Then we go ahead. So now we are approaching the evaluation of a endodontic treatment. For example, we can say, I want to treat this case, for example, for endoreason, the 2 central incisors. Or maybe we have to treat again. Or another case, we can have the chance to do, I don't know, some new case, or maybe we have already some endodontic treatment done, but can be kept, can be maintained because they are done in a proper way. That is one example, for example. Now we can clear it, and we can really push what is really needed for this patient. The same thing can be done also for direct restoration, indirect restoration, posts, and implant. So for example, we miss a couple of teeth, we put the implant in the cuspid and the cuspid, this area. We want to do post, maybe the other 2 cuspid, the lower. Or maybe you can have indirect restoration on the 2 central incisors. So just to explain to you that you can sign everything you need. You want to clear it here, just delay it. We just have maybe treated with the direct way, with the direct way, these 2 teeth. That's the real situation. Now we go ahead, and at this point, we have also the chance to use the periodontal chart. It can be simplified control, evaluation, or complete one. We go through simplify, and at this point, we can say, have you gingivitis? No. Periodontal disease? No. Periodontal support is intact. And biotype is quite thick. You can also have the chance to upload the image. You can take a photo, you can have taken from gallery. Okay? So, going ahead, another alert. All your data have been updated. Do you want to continue with data processing? So that is very important because now you can save and close, or you can go ahead, we can continue. What it means that now we don't need anymore the patient in front of you. We have already collect all the data that are now able to really do the treatment plan for this patient. So the patient can go home, you can stop here, go to other patient, and then you can do your treatment plan even tonight at home or maybe tomorrow in the office. So in this case, we don't save and close because we want to continue to explain to you. And now we have the chance to really do the treatment plan. Now we start, of course, with the facial analysis. That will be no more with the red circle, but with the green circle. So from gray become green, of course. And we start with the facial proportion. We can enlarge the image. I will push this button here. Now I can put this line to the ophthalmic line, to the base of the nose, and to the point of the chin. Now we know that the 3/3 could be more or less similar. Now we see we have 47%. So the lower third of the face is a little bit shorter than the remaining part, but still it's green. Let me take a look. If I had different situation, for example here, we see if I move this, become red. Look at the red circle from green become red. It means that at this point you have no good proportion. If it's like that, and I go ahead because I can go ahead, look, we have another alert saying me. This is an orthodontic or maybe orthodontic case. So if you want to follow the ideal case, you should send your patient to the orthodontist or to the orthodontic surgeon. But if you want to go ahead, in any case, you can push your orange button and you can go ahead anyway. It's up to you. You know that is a compromise situation. So going back once, I reposition in the proper way this situation here. Was more or less 47% as you see here. Now we can go ahead and check the profile. I want to enlarge the image, and again I position this on the glabella, this on the base of the nose, more or less like that, and then on the point of the chin. And now we check it, and we have 168, and the profile is called normal. Once more, if I maybe a protruded maxilla, look, from green become immediately red. If you have retruded one, the same. Okay? So we reposition the proper position. Let me do, I had to enlarge the field like that. And now we can go ahead. Now we have a normal profile. So going ahead, now we check where the teeth are positioned. We enlarge the image too. We go through this glabella here. We can see that more or less we are tiny bit inside, so we have some high palatal position that is a little bit out. Again, this could be considered a case that should be sent to the orthodontic surgeon, but once more you can select prosthetic compromise, and when you fix this, at this point you can go ahead. If not, if you push the green button, the case will be closed. So I can put continue, and now you have the chance to see about the definition of the central incisor length. We have already all the numbers. You see the ratio is absolutely red. The circle here is 103% of the width. The width is bigger than the length. That is quite not normal actually, because normally, of course, the width is 80% of the length. And remember, we have the tooth exposure at rest that is minus 3.5. What do you have to do? Now you have to enlarge the image, and this kind of red square box should be positioned in the patient mouth. Remember that we are in the central incisor. This is reproducing exactly the size of the tooth. So I enlarge this, I go moving this. Okay. So now we have finalized this, the red box, it will be in the right position. And this is the red box is showing exactly the measurement that we have done already. So we have already the length and the width. Okay, now we have another alert. It was asked us if you want to modify the width or keep the width. In this particular case, having the chance to see that the width is 9 millimeter, I want to keep it. 9 millimeter is okay, but automatically, to keep the ratio between the width and the length, between 75 to 85%, that's the minimum that we can have. 75 is still green, as you see. The app guides us to have 12 millimeter length. Still, the tooth exposure to rest is not good, is not visible. So are not good numbers looking at that. But the problem is that the patient has a lose my line. Don't forget it. So what it means? It means that even 12 millimeters, even though it's orange, will be not visible because the total length will be not visible at all. The upper lip will cover the cervical part of the tooth. So we could have maybe even longer tooth without knowing, without seeing. At this point, we will have still a red or orange value, but at the same time, the final tooth exposure at rest will become better and better. So, go ahead in this way. We can confirm or even edit. I want to personalize, customize my numbers. I want to push edit. And when I push edit, again, I could say, okay, that is 12 millimeters length. But as you know, the starting point for our treatment plan starts from the decision if you want to lengthen the teeth incisally or cervically. So the tooth exposure at rest is a very important step. We would like to see more teeth. So at this point, we can sign here and go to the green situation, like 0.6 for example. But automatically the length become red, 12.8. But at the same time, remember that the lowest line of the patient doesn't allow you to see the total length of the central incisor. So cannot be visible. At the same time, at rest, we have started to see the tooth. That would be an option, even though you know that the ratio now is orange circle, is no more, green like before. So another option is, you see the incisor lengthening normally is considered that is incisally related, as you can see also from the screen, but sometimes, many times, you maybe have to add not just incisally, but also cervically. Let me do the opposite. So I decrease this, but at this point you will have a better length of the tooth, become green, but you will not see the teeth at all. Tooth exposed at rest become red and is not visible. And you can have also the ratio that is going on well, so really remaining maybe 1.5, 1.6 instead of length. But then to obtain the nice final length could be lengthening the marginal cervical shift, elongating this way. So automatically on the drawings here, you can see that the length is divided between a part on the cervical area, a part on the incisal area. So that is a customized solution that you can do yourself. So in this particular case, we don't want to do any increase of length on the cervical area, not orthodontically, not surgically, but sometimes will be possible. So what will be now the nice point? We have the green situation in terms of length, but the length cannot be visible completely because the patient has lost my line. At the same time, you have not tooth exposure at rest. That is a valid reason why I would like to increase incisal the length of my teeth. I want to increase it, I'm doing, pushing here, become even red, but now we start to see, for example, the tooth, and we start to have 0.6 visibility. So we start to see the teeth. So this is really something that you can play with. Absolutely, there is no doubt that you can customize this value, depending on what you believe is the most important step for you. Repeating that in this case, not seeing the cervical part of the teeth, you can never see the total length, even though it's almost 30 millimeters. But at this point, you can show finally some tooth exposure at rest. But it's up to you. You want to keep the value the app gave to us automatically is orange value for the length, is minus 0.2 tooth exposure at rest. So you don't expose anything at rest, but as soon as you start maybe to move your mouth, you can start to see the incisor part. That will be acceptable anyway. So we keep this value that the app gave to us automatically. So we go ahead and now we check about the pupil. We can enlarge the image. Now we can move this pupil, we can enlarge, position more in place, then we reduce the size. Other pupil here. .5. So we want to follow the horizon, we want to follow the eyes, is up to you. Our final rehabilitation will follow for our consideration the horizon. But if you put bipupillar line, you will have the head that will be tilted until it's in horizontal place. So at this point I put horizon, that is the reference line they want to follow. I go ahead and then you have the chance to see, in this case, we can use this horizontal line that is the reference line. Going ahead, you have the chance to see that this level here shows you if the cuspid, for example, the right one is shorter than the left one, or if the second bicuspid or the first molar is shorter on the right side than the left one. So we have an inclination of this. On the contrary, if you, going back, have selected, for example, if you have selected not the horizon but the pupillary line, automatically the pupillary line become like an horizontal area. You see now the eyes are parallel, 100%. Now if you, with your rehabilitation, want to follow the eyes, you can go ahead in this case, and you have the chance to see that in this situation here, the two cuspids, this one is longer than the other one, on the molar are more or less the same situation. So you can avoid to move so much the occlusal orientation. You want to keep it like it is because it's more parallel to the eyes. That is an option that you can follow. So at this point you have a kind of tilting situation, but more or less in this case following the eyes that become an horizontal plane, it will be more or less ideal. You want to modify. And now you have the smile of the patient. You can ask the patient to smile. Check it again.
Fallo funzionare.
We can see this is quite flat. You want to elongate for that reason. And then we go ahead, pushing the red button. And now we have again to find this and to recreate with the new picture the size of the central incisor. The proportion was maintained, of course, and now he's asking us how many teeth do you want to treat it, how many teeth you can you see on the mouth. We said before that 12. So we continue, and we can now check it. For example, that's the value that we have already accepted. We want to increase this. Now the length that you want to add it. So now we're in the right position. We can also select the curvature. You have to select this one, but you can select also this one here. And that will be showing you that you can add some length here. You can decrease the length over here. Now we accept this situation here. Closing. Now, keeping this kind of measurement here, we want to go ahead and to see how much I can add here. So we see that cuspid on this area is shorter than the other one. We can say the level of the cuspid can be augmented. On the right side, maybe plus 1 millimeter, and maybe on the 23 plus 2 millimeter or 2 millimeter 0.5. And then we can see that the first molar that is there can be shortened on the let me see, that is the cuspid values, plus 1, plus 2.5, according to the line that you can see here, according to this line that it can draw over here, can move up and down. So also the first molar of the upper arch, right and left, we can shorten in this case, is minus 1.5. In this case, the 26, you have to add 1.5 approximately. So just to realign to have the new orientation of the occlusal plane. Now is the time to check about the buccal position of the teeth. At this point, we call the incisor profile. It is 8.9 data processing. I want to know exactly this. So let me check now. Enlarge the image. I take this. I put this on the tragus and the base of the nose. Tragus is more or less here. And then we checked. The nasus is more or less here. Yes, a bit shorter. And then we see at this point that we can have this. Let me enlarge the image. And we see now the situation here the right center incisor long axis. Seem to be a little bit more in. You see here, can enlarge even more. You see the tiny bit center inside right side is like that. Okay, it's less than 90 degrees. Normally it's about 90 degrees. Automatically that means that you can really put your teeth with the final restoration more out. Let me better explain to you. Now there is 88 degrees is the angle between compress plane and central incisor axis. Now there is written move backly 0.4 millimeter. It means that automatically you can have the chance to go more out, and that will be very good. Why? Because once you say that, and you have to confirm about the F sound, that the phonetic test that you have done, let me check with you. You see that the F sound is inside the vemion border of the lower lip line. So at this point, we can see that his lingual eye is about 2 millimeters value, lingual eye, like 1.5, 2 millimeters. So it means that we can go out a little bit more if needed. Okay, so are they similar to be wide labial corridor? Assess the possibility of reducing it by increasing the back surface of the upper teeth. So at this point we have all these teeth, and you can say, I want to add some volume on the back side. I want to do the entire mouth. I need to do the entire mouth for the problem of wear. Now I want to increase the labial corridor to close it to be this size. We can, go up to 1 millimeter everywhere. So now we have written there that we want to go more backly, 1 millimeter approximately in every teeth, from the bicuspid to the molars. So in this case, now we arrive to the final outcome, and we have another alert explained to us where you are. You are in the position in which you have really finalized your case, and you're ready to really send everything to your dental technician, or to talk to your implantologist, orthodontist, or any colleagues. So let me show you. This is actually what it was before. It means the dotted line is of course what it was the original situation. Now we started with the overbite that was approximately 3 millimeters, and now we have 6.7. But in this case, we forgot to, of course, say something about the treatment plan. It means that we would like to increase the vertical dimension of occlusion. As you can see here, our proposal in this case was that to augment the vertical dimension up to 3 millimeters anterior. And at this point, you have the chance to see that the overbite is decreasing and the overjet is increasing a little bit. So 3.5 is even more than that. Now you have already the tooth length is about 8 millimeter, 0.8. So to increase the vertical dimension on anterior area, you can have the chance to do different kind of things. It means that you can pushing the lower button here, elongate the tooth on the lower arch you see here, but then you start to see the tooth, the lower 41, that is becoming red. At this point you have contact, but you can do both. You can decrease now the length. We started with 8.8. Now you can go up to maybe 9.3, 9.4, still acceptable. But the remaining part will be related to what you do upper and saying I want to do some palatal thickening. You see that? And become closer to the contact. You can put one more and you'll be right in the contact right now. Possible contact there. Or you can start to say I want to reduce the medial alteration is too much, 3.5, become 3. At this point you can decrease still on the upper, the palatal thickening. Okay? So that's reasonable at this point. You have not all green, values. You have some orange values, some green values, some red values. That's the case that cannot be perfect 100%. So he can decide, you want to optimize the overjet, overbite, want to optimize the length, want to optimize the rest, exposure at rest. You can move upper or lower. And of course, at this point, you can have the chance to optimize as you like. You can have a different kind of option. For example, you want a less overjet, 3.2 is orange. If you still go to the upper and do like that, you become 3.7, 3.8, and then become red, or the opposite. If I go down, become green. So I can have overjet 2.8. At this point, you can also reduce the length maybe of the lower incisor, still keeping the contact, become now 4.3 and 9.3 in terms of length. You can do even more, it's 9.2. And you can put more lingual, the upper again. You still have a contact. So you can move it. You can have a customized value, or if you like it, you can keep the value that GETApp gives to you. What I want to explain even better now is that in this scheme here, you can find a lot of information, incredible number of information. I would like also to explain to you how to use the app. On this area here, you have the question point, and the question point is how to move your hands on this screen. So now you can understand that there is an explanation of all the questions you can have how to move your hands. So that is very, very important. Second, you have here, and you can click here and see immediately all the picture. Going back to the picture. And then you can have the red button here with all the explanation, and more than that, we have an important information here with the eye. We have the information of the possible treatment options on the overbite and overjet values. For each overjet and overbite that you will find at the end, you'll have different kind of advices in what to do. So how you can modify. So it is a kind of an iBook that is behind that, because it's guiding you 100%, explaining you why you do such things. And then you can have some notes, of course. You can write notes here, or you can also scroll all the previous steps that we have already followed. So it's coming back to 921. Okay? So now we're going ahead, and now we start to say, okay, now I have to finalize my case. What are the prosthetic solutions? Of course, what we do in this case is to increase the vertical dimension. We do the full arch on the upper, full arch on the lower arch. And of course, we need to cover completely the upper teeth, doing crown or full veneer, and just veneer on the anteriors on the lower arch. We don't need to cover completely the lingual area of the lower anteriors. So now we have this solution. It can be done in this way. Some cases when you have already some restorations, complete coverage on the lower arch. But if not, it's actually, like in this case, a normal case with the natural dentition, we can of course select this one. We go ahead again. We have the chance to see, do you wish to restore the other teeth on the lower arch? Of course, yes, we decide to do the full mouth rehabilitation. But you can also do just the upper, just the sixth anterior of the upper jaw. Of course, that can be possible. In this case was larger case, more complete, with the full mouth rehabilitation. Now, we have already some values. The length of the incisal edge, the central incisor of the right cuspid and the left cuspid. You see that all the values are already there. Plus, you can write down here, for example, you want to increase the length of the lateral incisor 2.7 millimeters. And at this point, you can have also the chance to lengthen, for example, the other one, 2.7 again. And we have not the value of the central incisor, should be more or less like the other one. You have the chance to see that the length of the two central incisors are more or less similar. So we have increased 3.3 there, and we can increase 3.3 also in the other one. So now you have all the value. We don't want to change the width that remain the same, so you can go ahead. Then we can see that now there is a kind of different situation. Now, when we look about the backal labial teeth movement, we can understand that there is a red arrows that is going to the lingual, 0.2. Why? Because we have moved this backal position on the rendering. So going back just a moment on 9.1, functional setup. We remember that we moved this. It was not like that. We did that to improve the overjet values, but we can maybe change our philosophy. Say, I want to go to the upper, I want to go inside the backal lingual displacement of the upper jaw, want to go more out. Automatically, we increase the overjet, but increase the overjet still going not bad because it's still orange, but at the same time, we can have the chance to put our restoration more out. It means that we can prepare less because we don't need to prepare more if you put your incisal edge. So now we have moved the incisal backal area more out. So it can move even more out. You see that overjet value change. But in this case, if I go more out like that, for example, of course, I will prepare the teeth in this area much less. I could keep it, I could maintain a proper way. And that is a nice kind of situation. So now we go back to this situation that we had before. So at this point, we have the sign 0.5 millimeter that is signed already. It is the refer tooth that we have selected already. It's the selected central incisor. And now we know that in this way we want to align the teeth, so I can put on the number 12, backally, or this, and we put 0.5 for each one of them, 0.5 each one of them. So we decide to align all these teeth, but now we want to increase it a bit more, the lateral incisor to be really in harmony with the backal position of the left cuspid that is already out. So now in this way we have compensated, and now we are in the same position with every teeth on the backal side. Good. Now, do you wish to furnish additional notes on the idealization of the anterior superior dental composition? We can do it. For example, we can have the chance to see, for example, the tooth-to-tooth proportion here, axial inclination, or interdental contact areas, interincisal angles, or the two positions of the lateral incisor between the two hypothetical lines that can be drawn on the incisal edge, on the cervical area. Lateral should be inside these two hypothetical lines. So all this information can be written down. Until you go to the lower arch, you can increase the view, you can better see the lower arch. Okay, we started with the need to lengthen the 41, so the central incisor on the right side of 0.4 millimeter already. So that was already said before. To the rendering, that was increasing the length as you have seen. Now, all the other teeth should be more or less aligned. We are missing one lateral incisor on the left side, the lower arch. And now we can have some adding, just tiny bit adding here, the 42, the 43. We can add some length on the 31, still 0.4, like the central incisor on the right side. And then 32 doesn't exist. 33 is in position, but we just add 0.1. We don't want to change the width, just maybe to wide the 33, and to wide just 0.3, just to close the little diastema that is present there. Now, what about the backal labial teeth movement? We have seen before in the step 4.1 that was nothing special. It means that was not lingualized, not backalized in the normal position. But to save tooth structure on tooth preparation modalities, we prefer to move tiny bit this kind of backal position of the lowers, especially because the overjet is already quite big right now, 3 point something. So we can add some backal movement. We select the move backally, and then you can select this, and we can put out more of 0.5 millimeter everywhere. So we have already positioned more backally all these 6 anterior teeth in order to prepare less, to be minimally invasive on the tooth preparation, because we gain automatically 0.5 millimeter in terms of preparation modalities. So we go ahead this, and now we want to have a laboratory work order. We do the wax up, we can do mock-up and direct mock-up or provisional prosthesis, or you also do the final prosthesis. So we can create already the final one just to show you what about some other aspect. So now we are using a semi-adjustable articulator. We would like to have this occlusion incisal guidance and the canine guidance. We want to use the face bow, the arbitrary face bow. You can put some notes if you want it. We go ahead and we can select also the setup of the articulator. We can have immediate Bennett 0, standardize the angle of Bennett, that is 10 degrees, standardize the condylar eminence, or maybe you can use the customized value, or use the value obtained with the protrusive record, like you did. And we can say, okay, now we have to do the full mouth rehabilitation. And we need to do, this is a full coverage. It can be a crown when you don't increase the vertical dimension. So you have to prepare in the normal way, because you're going to dentin, you need quite thick preparation. But if you increase the vertical dimension, you create automatically some space between the anteriors. You don't need to prepare the lingual part of the upper anterior because you have created space. So you just need to cover with your final restoration the back to the lingual part, creating a complete coverage. We don't call that crown, we call that full veneer, because we are not touching the lingual part. We just refine it a tiny bit, and we kept all the enamel that is present there. So full coverage, I click full coverage. A full coverage will be from cuspid to cuspid. Plus, I push the yellow button, occlusal coverage, will be done in every other place over here. Then can be the partial coverage, can be complete coverage, but normally what I need is to increase the occlusal part to have a nice occlusion in the higher vertical dimension rate. Now the lower arch, on different side, we have back coverage that we don't need to have any complete coverage on the lower anteriors. We just do veneers, back coverage only, and again you have occlusal coverage over here. Of course, if you have a crown, for example, I don't know, in the central, in the first molar, you can put different. You can put full coverage here and become a crown instead of having occlusal coverage. But in this case, we have just occlusal coverage. We have not any kind of extension to the gingival area because we don't need it in terms of aesthetic, in terms of structure of the tooth. So we go ahead, and now we select the restorative material. We can use the material you wanted. We are looking at this material. I can select the first one, and what they ask me, which one of them are you using here? You can say monolithic zirconia, layered zirconia, monolithic lithium disilicate, layered lithium disilicate. So on anteriors, I would like to say layered lithium disilicate. And they are asking me, what kind of material want to use for every teeth or for the same area? I say, yes, of course. So in this case, I have all the anterior teeth, 11, 12, 13, 21, 22, 23, the same solution. What about the posterior area? Again, I would like to use monolithic lithium disilicate. So I push this, and automatically all the same kind of restoration will be automatically positioned the same way. Now, we just last the veneer on the lower arch, and the veneer in the lower arch, I do the layer lithium disilicate, and again, that is for every teeth, the same space, the same characteristics, so all veneers. Now, going ahead, now we started with the initial color that was A3, that was the A3 color, with a pan shed guide. If we want to increase the value, so I go to A1 now, from A3 to I value. And then abutment color, you can select the color of the abutment. In this case, we have a very nice situation, normal tooth, so I can put number 2 in all these teeth, number 3 in these two cuspids, in these cuspids here, and still number 2 in the other 4 anterior teeth. So as this is the color underneath. the abutment color. Now we have the summary of the frontal view, the dimensional changes. You have to increase the length of 1 millimeter on the left first molar. We have to decrease the length of the first molar on the right side because the inclination of the occlusal plane. We have to increase the length of these upper frontal teeth that are shortened by the wear, by the grinding procedure of the patient. We have to lengthen a tiny bit also the lower arch, not so much because the lower arch is already visible and the exposure at rest of the lower anteriors are already about 3 millimeters, so we cannot elongate too much the lower anteriors. More, you can add some buccal, so some lingual thickening of the lingual part of the upper teeth. So we have the original length was 8.72, original width 8.99, but then you have to add all these values that are added. And then we need to go more out. We position the teeth more out. The only one that is not really that is not really positioned more out is the left cuspid that was already more out. So we go also out with the lowers. You see the arrows, there are the arrows, 0.5. Labial corridor also were moved backally, 1 millimeter approximately. So now we have the resume. Original overbite is 3.5, now is 4.1. Is on the border, is a limit, but still good. 1 millimeter over overjet was the beginning, 3.3 now. That's much better to have a flatter the flatter anterior guidance. The video alteration was 3 millimeter. We have also the summary about what account the occlusal coverage we have selected, complete coverage on the anteriors, on the upper jaw, partial coverage, so buccal veneers of the lower jaw anteriorly, and both cages, and posteriorly on the upper lower jaw, we have selected just occlusal table or some onlays or buccal occlusal veneers. Now with the final notes, you can write down all the requests to dental technician or to your colleagues like orthodontists, implantologists, to really have the chance to ask them if they can really contribute to finalize the case, if they agree with what they have seen together. Another important step is that it can be shown also to our patients. The patient can be aware what you do and what is the role that you really have to indicate to the dental technician exactly what are the need of the patient, because the dentist is the only one seeing the patient that is capable to understand, following this step-by-step procedure, how much you have to increase the length, how much you have to increase the buccal position, how much you have to increase the vertical dimension. So all these steps are needed to be really in charge to finalize the case in a perfect way. This is a case in which we have done a full mouth rehabilitation, but that is the most complicated cases. You can also have the chance to treat only the 6 anteriors, for example, and of course will be shorter and faster. So at this point, we are ready to finalize and to do the final PDF. You have to put the date. Today is 20 April. Now close and create the PDF. Now we are uploading the case. So when the PDF is ready, I go back to library. I go to the patient, Roberto Ragazzoni. Now we have the PDF. I can click it. I can download with the Adobe Acrobat. And automatically all the information, comprehending the pictures, comprehending also the videos of the patient, the aesthetic information, the functional information, the regional overbite, overbed, the final one, the articulator setup, the color selection, the abutment color, the laboratory order, with all these type of restorations, occlusal, buccal, or full coverage, type of work, the material, ceramic material that we decide to have it, for each tooth, and then also all the dimensional changes that we needed to make in this case. Upper, lower, the frontal view, occlusal view, the buccal position of the restoration, the buccal lingual change, And that is what we have now for our dental technician or for our colleagues, being an orthodontist or implantologist. They will have all the information they needed to really catch the final outcome in terms of occlusal plane orientation, position of the teeth, and the treatment plan of this patient will be already made, that is ready to be treated. Now we are ready to send all this information to our colleagues and to our lab technician in order to be able to finalize the case in a perfect way. We are still working on the app, improving day by day many different steps. We are in position to really improve the final outcome of the app without any kind of additional payment. It will be automatically found on the app when you open it. I hope you enjoy our presentation on GETApp. If you need more information, please go to our website, fradeanieeducation.com.